Bismillah Rahman Rahim. In the name of God, most gracious, most merciful. CTG, cardiotocography. I am Dr. Muhammad Hashim Wahaj from Kabul, Afghanistan, Wahaj Hospital. In the past I was working in different departments, and I am the Afghanistan director of Jefferson Institute of Ultrasound and Research. Also, I am director of Ian Donald International School of Ultrasound, Afghanistan branch. This is Dr. Preeti Gupta, and because of whom I am making this lecture, because she requested me that you make a lecture for CTG, because when I was in Jhansi, she was very busy and was not able to attend my lecture. So this lecture is dedicated to Dr. Preeti Gupta. At 30 weeks or at the time of labor, two important factors must be taken into consideration: uterine tone and contraction, whether it is able to propel fetus and deliver, condition of the fetus, whether it is normal, okay, or under stress. So we should know about the uterine tone and contraction and condition of the fetus. Our attention is on the fetus itself. That is the fetus well in developing normally? Is the fetus able to complete full term? Is there any alarming markers? How long we should continue the pregnancy? Should we plan for early delivery or operation? At the time of labor, how is the condition of the fetus? How is the uterine contraction? Information about the above two important questions will help us to allow the mother to continue normal delivery, to do immediate operation, and what are the benefits of CTG. Saves life of mother and child, avoids unnecessary operations. Nowadays, cesarean section is done almost in most of the government and non-government hospitals. But is it necessary? Should we allow the mother to continue and do the normal delivery? It is the CTG which will help us. Long time before, in 1876, they were using this instrument, and then after that they were using this instrument, but now they are not used. For now, we are using CTG unit to know the fetal condition and also the contraction of the mother uterus. What is CTG? Oh God. What is CTG? CTG is cardiotocography. Cardio means the fetal heart, toco the uterine contraction, and graphy recording. So CTG or cardiotocography is the recording of the cardiac activities of the fetus, heartbeat, toco the uterine condition, and graphy means we are taking a graph. Hypoxia or lack of oxygen, they are intrapartum. Hypoxia is a significant cause of fetal death and disability. In theory, the worst consequence in the majority of the adverse outcomes of the intrapartum hypoxia can be avoided. This was one of the Foxy conferences. Our friend who died, and these are other friends. What is the CTG unit? CTG unit is a unit which has got two probes, and these probes are put on different parts of the body. Number one, it is at the fundus, near the fundus of the uterus, and the other is on the place where the heart of the fetus lies. So CTG machines can be with wire, or we can have wireless units. One for the cardio, we will put it where we feel the fetal heart, and for the toco, we will put on the fundus of the uterus. So we put toco here. The important thing is the CTG paper. As in ECG, we should know the paper and what are these squares. The CTG paper has got two portions. One is above, it is for the fetus, fetal heart rate we will measure here, and then the other one is the lower part is for the uterine contraction. And these squares, they mean something. They are divided 25, 50, 70, 100 or 2, 4, 6, 8, 10. It is for the contraction, and we are doing ICSI in Kabul, the first ICSI in Afghanistan. So as you may know, ICSI is a procedure in which we help the couple to get pregnant. Okay. The horizontal line indicates time in second. This portion indicates time in second. And the vertical is fetal heart rate. And this is divided by 30, 60, 90, 120, 150, 180 and 210. In between we can have 190, 200, etc. One big square. We have got one big square, and then we have got small squares. What does one big square means? From one bold line to other bold line, it is 60 seconds. It is, the time is 60 seconds. And in the vertical, from one bold line to the other bold line, it is 60 beat per minute. And you check that it has got how many small squares? 1, 2, 3, 4, 5, 6. So it means one small square is 10 seconds. Then this is 20, 30, 40, 50, 60. In the same way, vertical line, they have got, because the whole is 60 beat per minute, each is 10 beat per minute. This is very important because we make calculations, and you should know about these measurements and what these small squares means and what the large square means. The small square, I said, from one line to the other line, it is 10 second and horizontal, and 10 beat per minute and vertical. So these measurements are very important. Conference in Lahore, our friend Dr. Narendra Malhotra, Sham, and all other colleagues from Afghanistan, Nepal, Pakistan, Bangladesh, we were over there. Looking at the CTG paper, we should know that it should be symmetrical. Check the name, check the speed, check the time and the date, check the maternal pulse, define risk and indication of the CTG monitoring. When I put a picture, for example, I put my picture, how long it will take for you to recognize me? If you know me, no time will be taken. You will say, yes, he is Dr. Wahaj. But if you don't know and you have not seen him before, me before, then you will think, finally you may make mistake. CTG paper is the same. Once you see the paper, the result, the graph, as you recognize a picture, you will recognize within a second that whether this CTG is normal or it is abnormal. Pattern recognition, we call it. Recognize a pattern is a daily job. Recognizing a pattern is a daily job. How you recognize a car, face, etc., which I have said. Check your paper speed first. Most of the papers, they are 1 centimeter per minute. Some they adjust their machine 3 centimeter per minute. In UK it is 1 centimeter per minute. In Afghanistan, in India, again it is the same. And what is yours? Do you have any changes? You have made changes? Does it need to be standardized in Afghanistan or in India? So we don't need much standardization because we are using the same 1 centimeter per minute. Baseline in gestational age. From 14 weeks to term, there is a progressive fall in the mean baseline fetal heart rate, which is unaffected by whether the fetus is active or quiescent. So there is a change we should know. Effect of medicine on CTG also, if a mother has taken betadine or methyl-dopa, the rates will be different. Annual conference of Aon Donald in Zagreb, Croatia, and he is Professor Asim Kuriak, Dr. Frank, the grandson of Aon Donald. Here is me and other colleagues. Classification of CTG. What is the result of CTG? When we do a CTG, we should give result. So the results could be normal, suspicious, or pathological. What these three things help us? If a lady comes for delivery, if the CTG was normal, you can tell her, okay, go home. When your real pains started, you can come back. So we have no issue in this case. If there is suspicious, what we do, we take the lady under observation. But if it was pathological, within no second we ask shift to the OT and do the cesarean. So it's quite easy. CTG will help us in deciding what to do with the patient. Sometimes when you do operation, you do cesarean section, and then the family and they sue you. They go to the court. Why you did unnecessary operation? But if you have a CTG which is pathological, it will save you because you will have a very good reason for doing the operation. There is for the interpretation of CTG, we have got a formula which is called Dr. C. Bravado. What is this? Determine risk. It is doctor. DR. Contractions, we see the contractions of the uterus. Baseline rate. Baseline rate. Then variability. We see something which is called variability, which we will go and discuss in detail. We have got accelerations. Do we have accelerations? And then we have got decelerations. Do we have decelerations? And then overall assessment. So the result or interpretation of CTG is done by this formula, Dr. C. Bravado. Define risks, whether it is a high risk or low risk. Contraction, frequency and length of contraction we will note. Baseline, whether it is bradycardia, normal or tachycardia, we will differentiate. Variability, 5 to 10 beats per minute, whether it is present. Acceleration, we will quote that it is present or not present or absent. Deceleration, Again, we will say whether it is present or absent and which type it is. Deceleration has got different types. Different type will indicate different pathology. Outcome, whether it is normal, suspicious, or pathological. This is a graph for the contraction. It will give us the information from one peak to the other peak, the duration, the frequency, the all information will be given on this graph. And this is the second contraction. These things are very important. Here we have got a graph. We see the duration, the frequency, peak to peak. We will make it frequency beginning to the beginning, beginning to the beginning. How often it happens and what is the duration, and it has got a very good contraction. These are the two things. We were invited by Professor Dr. Gupta and Jahansi, and there was a hysteroscopy workshop by Professor Osama Shauki, the magician of hysteroscopy, and we were glad that Dr. Nayak was also there. So she welcomed us very warmly. 4 features of CTG. Baseline, whether it is reassuring, non-assuring, or abnormal. About the baseline, we have to make these comments. Variability, whether it is reassuring, non-assuring, or abnormal. Deceleration, whether it is reassuring, non-reassuring, or abnormal. Number 4, acceleration, lack, unknown significant in the labor. So these will decide whether we label the CTG as normal, suspicious, or pathological. Baseline heart rate. The mean level of the fetal heart rate when stable, acceleration and deceleration being absent. The normal heart rate baseline is 110 to 160 beat per minute. Just learn this thing. Normal is between 110 to 160. The fetal heart rate is between the pediatric changes and they call the baseline fetal heart rate. The normal baseline heart rate varies between 110 to 160, slightly quicker for preterm. A baseline fetal heart rate of 100 to 109 beat per minute or 161 to 180 beat is non-assuring. Non-assuring. But a baseline fetal heart rate of less than 100 or more than 180 beat per minute is classified as an abnormal feature. So we have got 3 patterns between 110 160, which is called normal. Between 100 to 109 or 161 to 180, it is non-reassuring. But less than 100 or more than 180, it is pathological, abnormal. Wherever the graph lies, that is the area of heart rate. See, maximum it lies here. So it is between 140 and 100. This is 100. So it is about 130. Look at a paper from the side. Watch for creeping baseline. Look at the side of the fold paper. So from one side you can check. Now here what we see, here's a CTG. This is the graph of fetal heart rate, right? Where it lies, it is 160 and 180. So it is about 170 it could be. So when it lies between this two number, so it is 170. Here we see that is 150 and that is 120. In most of that it lies between 110 120 to 90. So it is maybe 110 or 100. Here where it is another case, you see that is 150, 180, and just it is near 180. So this lies here, and you see good contraction. For contraction in this case we have got no problem. The baby which I was working with, my teacher Professor R.K. Sharma, and a couple who delivered. Variability. What is variability? Degree to which the baseline varies within a particular band with excluding acceleration and deceleration. If the variation is between 5 to 15 beat per minute in one pattern, so that is called variability. Represent contraction of nervous system, which determines the cardiac output and heart rate in response to various venous return and metabolic demands of the fetus. See, this is the heart rate, but you see it has got a variability. It comes down, it goes up, it comes down, it goes up, it comes down, it goes up, it comes down, it goes up. But this going up should be about 5 to 15 beat per minute. Number, see, this square is 10, this square is also 10. Now it is 20. So this variation in heartbeat is called variability. This is the difference between the upper and lower limits of the baseline heart rate over a short period of time, for example over 1 minute. So in 1 minute when we see how much variation is there, variability is a good thing. Now we see from here to here is 10 beats per minute, but now you see from here to here it goes to 10, then again it varies, again it varies, and again it varies. So it is between 5 to 15 beats, more greater than 15 beats per minute. So we call it baseline variability. Variability between 5 and 25 beat is considered reassuring. Reduced variability less than 5 beat per minute can be physiological during periods of fetal sleep. So variability is a positive sign. There should be good variability, but if there is less than 5 beats per minute variability, it means the fetus is in problem. Baseline variability, you see here it is very few, but here once it goes, so we can see the baseline variability. Variability of less than 5 beat per minute is considered a non-reassuring feature if it lasts between 40 to 90 minutes. If in a 40 to 90 minutes it is less than 5 beats per minute, then it is non-reassuring. But if a variability of less than 5 beats per minute for more than 90 minutes, then it is abnormal, pathological. Here we see the variability, degree to which the baseline varies within a particular band with excluding acceleration and deceleration. Then we will come to what is acceleration and deceleration in soon. But here you see there is no variability. There is very less. Here is very less. Here is more than 25, right? We can see this is also called silent, only one variability. It is reduced variability, it is good variability, it is a contraction of uterus, it's the same. And here is a lot of variability, 11 to 25. So that is normal variability, and also in sleeping. So this is the classification of baseline variability. Good baseline variability, see, it has got rate between 110 to 150, see, 120 to 150. Sometimes it comes here, but it is more than 120. So that is the baseline. These are the contractions, good contractions. Acceleration. What is acceleration? Acceleration are an essential feature of non-laboring CTG. However, in labor, the fetus may preserve energy by reducing its movement. Therefore, the absence of acceleration in labor is common and is of no known clinical significance. Acceleration, a transient increase in fetal heart rate. If it is a transient increase of 15 beats or more and lasting for 15 seconds or more. If here it is the baseline, which is 150, when it increases of 15 beat per minute or more, and then it continues for more than 15 seconds. So from here to here it is 10 seconds, and then it is 20 seconds, and here it is also, this is called acceleration. Here also we have got an acceleration. This we don't do, it has got more beats, but the duration is not 15 seconds. So this is not called acceleration. So acceleration is when it is more than 15 beats and more than lasting more than 15 seconds. So that is called acceleration. Two features, 15 beats or more, 15 seconds or more. That particular part is called acceleration. Here also we can see one acceleration. Here we see another acceleration. So these are acceleration, good contraction. We said the lower portion is about the contraction, upper is about fetal heart. See, one acceleration. Here also accelerations, we can check. A conference in, I think it was in Islamabad. Deceleration. It is the reverse of acceleration. A transient episode of slowing of fetal heart rate below the baseline level, more than 15 beats per minute. So 15 beats per minute it should lower, 15 beats per minute it should be lower, and lasting 15 seconds. So 15 seconds or more, 15 seconds or more. So this is called deceleration. The presence of deceleration is a non-reassuring or abnormal feature in a CTG, and it is classified according to the type, duration, and frequency of deceleration. One is called early deceleration, when the deceleration and contraction occurs at the same time. Here is the contraction, here is one contraction, another contraction, another contraction. When deceleration and contraction happens at the same time, both of them are happening at the same time. Here is also a deceleration. So this is called early deceleration. occurring at the same time as the contraction. This is called early deceleration. See, here is a contraction and here is a deceleration. Here is a contraction, here is a deceleration. Two decelerations. Early deceleration, you see, that is a deceleration and here is a contraction. Same at the same time, both are happening. When both are happening at the same time, so this is called early deceleration. Here also one deceleration, here deceleration, and it is contraction. Late deceleration. Late deceleration occurs after the uterine contraction. Now here, see, here is the uterine contraction, but the deceleration, here is the uterine contraction, you see the deceleration, it is after the contraction. Another one is here, here is the contraction, and you see the deceleration, it happens at this time. Here is the contraction and the deceleration occurs here. So this is called late deceleration. Late deceleration must be uniform in both length and depth. For this reason, true late deceleration are uncommon. More commonly, they are atypical variable deceleration that have been wrongly classified. Late decelerations are one feature of uteroplacental insufficiency. When there is late deceleration, so it is a sign of uteroplacental insufficiency. See, here is we can see contraction here, deceleration here, contraction here, deceleration is here, contraction is here, deceleration is here. This is the contraction and that is the deceleration. Once upon a time in New York, Manhattan, late deceleration, again we can see it is the contraction and here is the deceleration. Here is the contraction, here is the deceleration. Contraction and deceleration started here. Early versus late deceleration, you can see both of them. So in early deceleration and contraction happens at the same time, while in case of late, contraction happens, then deceleration. Variable deceleration. Variable in length and amplitude are not uniform, unlikely early and late deceleration. So they are typical. They have got atypicals also. So here you see the contractions, deceleration appears here. It is a contraction, deceleration appears here. So different in shape, variable, deceleration with variation in shape and timing. It happens before the contraction, it happens after the contraction, so that is called variable contraction. When we reached Jhansi, me, Dr. Professor Osama Shawki, his son and me, so we were warmly welcomed by Dr. Priti Gupta, her beautiful sweet daughter and other members. Typical variable deceleration, a transient episode of slowing of fetal heart rate below the baseline level, more than 15 beats per minute, lasting more than 15 seconds or more. See, it is more than 15 and it is more than 15 according to the time and the beat. It is deceleration, typical. So we have got different types we mentioned. Now we come to classification of fetal heart rate trace features. The features are three: reassuring, which is normal, non-reassuring, and then abnormal. If the baseline is lying between 110 and 160, it is normal. If variability is less than or equal to 5, it is normal. No deceleration and acceleration if present, okay. But non-assuring, if the heart rate is 100 to 109 or 161 to 180. In variability, if more than 5 for 42, less than 5 for 40 to 90 minute. But if it is deceleration, typical variable decelerations, so it is non-assuring. Absence of the acceleration with otherwise normal trace is of uncertain significance. Abnormal, less than 100 beat or more than 180, or sinusoidal pattern, etc., or less than 5 beat per minute for 90 minutes variability, and deceleration, typical decelerations, which we will discuss. Categories we have: the normal, all 4 features are classified as assuring; suspicious, 1 feature classified as non-assuring and the remaining features classified as reassuring; pathological, 2 or more features classified as non-assuring, or 1 or more classified as abnormal. So when we put this on our previous graph, so we can say whether this CTG is normal, suspicious, or pathological. The same, explaining again, that is sinusoidal pattern. So we may have sinusoidal pattern, which is also an abnormal pattern. Red flag, loss of variability, complicated tachycardia. These are very important to notice. Again, Professor Priti Gupta welcomed me very warmly at Jhansi railway station. Contraction assessment. The external transducer detects the frequency and uterine contraction but not their strength or duration. The optimum frequency of contraction is 4 to 5 in a minute. It is important to notice that contraction frequency to detect hypercontractility is more than 5 contractions in 10 minutes, and also to characterize the deceleration. Suggestion to improve: CTG training of the courses we should take, annual mandatory CTG training, preferably online, CTG weekly meeting to discuss interesting cases, make the definitions of CTG findings as standard, make the speed of the machine standard. When it is doubt, ask for a second opinion. Practice, practice, and practice. Good documentation. Legal cases to be judged by an expert in interpretation and labor management. Any other suggestion? So, when there is head compression, there is early deceleration. Early deceleration indicates head compression. Umbilical cord compression when there is late deceleration. Umbilical and uteroplacental insufficiency when there is also late deceleration or late deceleration. For umbilical cord compression, it is variable deceleration. When it is variable deceleration, this happens after contraction, this happens at the time of contraction, and the rest. So we have got 3 categories. Head decompression when there is early deceleration, variable deceleration indicates umbilical cord compression, and uteroplacental insufficiency indicates when there is late deceleration. So by seeing the decelerations, we can judge head compression when there is early deceleration, right? Early deceleration, so it is head compression, early deceleration, so a head compression, umbilical cord compression, it is late deceleration. So contraction here and there is deceleration. Contraction is here and it is deceleration. Contraction here. So in late deceleration, it is umbilical cord compression. Late deceleration we can see here also. Here is the contraction and here is deceleration. Here is the contraction, here is the deceleration. Uteroplacental insufficiency when there is variable decelerations. So contraction lies here, one is lying before, one is after, one is in the after. So variable deceleration indicates uteroplacental insufficiency. Which one it is? Here is the contraction, but here it lies before and after. It is variable deceleration. That is sinusoidal fetal heart pattern, which is abnormal. Fetal tachycardia, see, it is up near the 180 and there is no acceleration, no variability. Fetal bradycardia, when it lies below the 110, so it is bradycardia. Fetal heart rate, again we said we are measuring here. So it will lie between 110 to 160. Normal is 110 to 160. And bradycardia is between 110 to 109 or less than 100. And tachycardia is more than 160 to 180. Bradycardia, a baseline FR persistently lower than 110, and these are the causes when it lies here. Tachycardia when it is above the normal range, and these are the causes. Special patterns, we have got some special patterns which is called sinusoidal. So that is the sinusoidal pattern which I have shown you before. Pseudo-sinusoidal pattern also we can have. These are all abnormal patterns. Check mark pattern, these are also abnormal patterns. Solitary pattern you may have, these are also abnormal patterns. Lambda patterns, so it have got acceleration, deceleration like this. So these are also abnormal patterns. Thank you very much. Hope you have learned something from this, and if there was any question, you can call me, you can ask me. My WhatsApp number is +93 799 83 3217.